Great, thank you for having me. Thank you, committee, for inviting me to talk about one of my favorite topics. How does this work? This. The green, oh yeah, I got it. Okay, thank you. Here are my disclosures. I'm not going to talk about any of these items except for my own past medical history of calcium oxalate stones. So you take that into consider with a grain of sodium chloride when I talk about that. This is the most important stone. It was in my right uteral pelvic junction in 1995. It was treated by shockwave lithotripsy, and it was turned me into a kidney stone doctor, which is proof my wife says that I'm a narcissist. This is my intravenous pyelogram, and I just want to point out this is why kidney stones are so painful. You see that the stone on the right side, I don't know if you can actually see it with the lights on here, but the kidney on the left has got contrast in it. It's not obstructed. It's flowing freely. The kidney on the right is completely obstructed. The contrast is hung up in the kidney, and that's why this is such a painful thing. The kidney's completely obstructed. And I wrote about this episode in a story called Cocktail Party Nephrology, which was published in JAMA in 2013. I walked into the emergency room at Columbia. I'm a nephrologist, I said, and I'm passing a stone. And then, feeling that famously unparalleled pain, I added what seemed the unnecessary addendum. I need 150 milligrams of Demerol. So it's a little bit embarrassing to come to this committee and say, there I was in the emergency room demanding an opiate. And that, back in 1995, was certainly the way that I treated patients with acute obstruction and renal colic, and it was certainly something that I didn't know better. That had been my previous experience, that was appropriate and good relief of pain. Kidney stones usually present with what's called renal colic. Sudden onset, radiates anteriorly downward into the genitals, and once you've had a kidney stone, the next time it's pretty clear, and you won't be thinking, do I have appendicitis? It's progressive. It's usually considered the worst ever. Women generally consider kidney stones worse than labor, although the advantage of having a kidney stone is that you don't have to put it through college. It is often associated with nausea and vomiting, and sudden and complete resolution. Like that, it's gone, and you realize that the stone has passed. And the management of kidney stones has generally been with nonsteroidals or opioids. And the traditional ER choice is ketorolac or Toradol. Non-sedating, a little bit more expensive, but because this is usually a short-term issue, and usually the stone is going to pass, and we say it's going to pass, that's up to 4 weeks it's going to pass. So it could go on for a while. And opioids turn out to be a little bit cheaper if that's a consideration. Diminished ureteral contraction may be important, and opioids don't do that, and that may be an important consideration in relief of pain. Gastric irritation, of course, and the decreased GFR is commonly used, and you saw Dr. Friedman talked about why nonsteroidals are avoided in patients with chronic kidney disease with low back pain. I don't really think this is an issue, and I think it's not an issue because, again, this is a short-term issue. Hopefully this is going to go away. The kidney stone is either going to pass or a urologist is going to remove it. And so I personally don't worry at all about the effects of nonsteroidals on kidney function in patients with kidney stones. And opiates, the traditional use is still morphine. Certainly the Demerol that I demanded and I received is really out of date, associated with more nausea and vomiting. So at NYU right now, there is no meperidine available. Of course, the opioids, as you well know, are sedating, and the potential for opiate misuse syndromes and addiction are really not discussed in any of the literature or the clinical guidelines. And of course, constipation really is an issue for patients who take it on a common thing, on a common chronic basis. The other things that I'm not a surgeon, I'm a nephrologist, I'm the kidney stone prevention person, but I wind up, because my prevention therapies don't always work, I wind up treating many patients with kidney stones, and most of those via email or telephone. Very often when they arrive in the emergency room, the ER doctors call me about my patients, and so I do have procedures. So I don't do these procedures, but I do wind up treating lots of patients like this. And I'll just point out that the urologists also talk about opioids and nonsteroidals for the management of kidney stones, which includes ureteroscopy, going up the kidney, up the ureter to get to the kidney, or percutaneous nephrostal lithotomy, going through the back to get to a kidney stone. And there's some discussion about how to manage the pain associated with these procedures as well. Just to show you one example of the literature, which is pretty well comes out in favor of nonsteroidals as compared to opioids. Here's a study of 70 participants who received either 60 milligrams of ketorolac or 100 milligrams of meperidine. So again, an older study where meperidine was commonly used, and looked at the degree of pain relief, the need for rescue medication, and the time to discharge from the ED. I'll just point out, all of these studies are short. They don't necessarily follow up patients adequately for long-term follow-up. And I'm really discussing pain here. I'm not discussing stone passage, which is a separate question. So in this study, the patients treated with ketorolac, you can see that they're just looking at 90 minutes. It's very similar to what Dr. Smith talked about, the fact that this is acute, but can turn into something chronic that goes on for weeks until a stone pass. So you see the graphs on the dotted line of the patients getting ketorolac. They had better scores than the patients getting meperidine. So these are short studies that don't last very long. So what are the guidelines? The European Association of Urology guidelines are as follows. In acute stone episodes, pain relief should be initiated immediately, of course. Whenever possible, a nonsteroidal drug should be the first choice, and the second choice should be opioids. The use of alpha blockers, which reduce colic to is a question, and whether they promote stone passage is controversial. The Europeans have basically decided that, based on a study in The Lancet about 3 years ago, that alpha blockers are not effective in promoting stone passage. The American urologists still think that they're relatively inexpensive, relatively safe, and are still prescribing alpha blockers as basically not harmful, may be useful for some stones. So the AUA, the American Urologic Association guidelines, do not address this in any way. The guidelines on surgical management talk about surgical management, but not relief of pain in renal colic. But the AUA has addressed this to a degree. So here, as an example, is the medical student curriculum on kidney stones on the AUA website. And I've just highlighted, they say, nonsteroidals have shown equal or greater efficacy of pain relief and a shorter time to reach adequate analgesia with equal or fewer side effects. I don't necessarily agree with what follows. Here they talk about the NSAIDs promoting threat to renal function because of decreased blood flow. I'd say, so what? It's short term. Let's not worry about that. And there are pretty good studies showing that while they talk about NSAIDs causing platelet inhibition and risk, including surgical bleeding, surgeons don't worry about that at all. And there are good studies demonstrating that those are not things, I believe, that really are issues if the patient is going to go to the OR and have a ureteroscopy or percutaneous nephrostal lithotomy. And then pain is effectively controlled by decompressing the obstruction. Of course, ultimately, if you're really obstructed, you're going to get a stent placed or have a perc put in, something to unobstruct the kidney, and that's ultimately going to be the big issue. But the NIDDK currently has a study going on about how to deal with stent pain. You put in a stent, and the stent itself is associated with a lot of side effects, and there is a randomized trial being promoted by the NIDDK right now to look at how to deal with those stent pain, because the pain is often thought to be worse than the kidney stone itself. Patients hate stents to some degree. And the Choosing Wisely campaign, which Dr. Friedman highlighted for low back pain, the AUA has addressed this, and they basically say don't continue opioid analgesia beyond immediate postoperative periods, prescribe the lowest effective doses and the number of doses. These are obvious points, not necessarily evidence-based, but certainly the AUA has endorsed that idea. And this is the Choosing Wisely handout for patients, which is on the AUA website and also goes through some of the obvious issues about lowest doses and understanding risks and side effects. There is a Cochrane review demonstrating that nonsteroidal anti-inflammatory drugs versus opiates for acute renal colic. And this is basically 20 trials, 9 countries, 1,600 participants, where both nonsteroidals and opiates led to clinically significant improvement in patient-reported pain scores. 10 out of 13 studies showed lower pain scores in patients getting NSAIDs. Patients with NSAIDs, of course, were less likely to require a rescue or a second therapy. The majority showed higher incidence of adverse events in patients treated with opioids, and meperidine looked bad. So the conclusions, both NSAIDs and opioids can improve effective analgesia. Opioids are associated with higher incidence of adverse events, particularly vomiting. All of this is very similar to what Dr. Smith and Dr. Friedman talked about with respect to their patients. And I'd say, therefore, that there is pretty good consensus. Now, Brian Eisner is one of my good friends and collaborators. He's a kidney stone surgeon at Mass General at Harvard, and I spoke with him about this last week. He said the joke of it was that at the AUA, which was in Chicago in May, every friend said from every foreign country, why do you guys give opioids? And that's because there were a number of research studies. I'm going to show you a couple of them. I was amazed that this was a very big issue. Brian said, yes, the people in South America, Europe, Asia, they don't use opioids at all. Why is the AUA meeting so focused on this? It doesn't exist in our country. And here's a couple of tweets that Brian had collected for me from Mexico, from India, from the UK, where people were basically not using opioids at all, and astounded that this was a topic of research at the American Urologic Association meeting. So I think the consensus regarding opioids clearly exists. Most patients do better with NSAIDs. No study looks at this and comes up with a superiority of opioids. That's very clear. The risk of addiction, overdose, opioid misuse syndrome are not discussed in any way. There's no long-term follow-up in these studies. So the question about that as a potential adverse effect is really not dealt with. And I don't think that we need further data regarding the management of acute renal colic. I think it's pretty clear. I think the anecdotal data from patients or from doctors abroad is very clear. So let me show you the reality. These are two posters that were shown in May at the AUA at a poster session that I moderated, where there were actually several other studies about this question. So here they looked at the NHANES data, questions regarding a history of kidney stones. Subjects were classified as using an opioid if one or more of the prescriptions was labeled a narcotic analgesic, and they did a multivariable logistic model. So in this 23,000 patients included in the study, there was a history of kidney stone in 8.8%. So this is one of the things about, unlike sickle cell disease, this is an extremely common thing. We usually say that 12% of American men and 7% of American women are going to have at least one kidney stone in their lifetime. So 8.8% had a history of kidney stone, and a history of opioid use within the last 30 days, 6% of Americans responding to this. And that turned out to be highly correlated with whether or not they had a history of kidney stones. The people who had kidney stones, yes or no, 10.9% of people who with a history of kidney stones were using an opioid. Now, whether that opioid had been prescribed for kidney stones or not is not clear. And the number of kidney stones that the patients had was correlated strongly with their likelihood of using an opioid or not, going from 6% of patients were taking an opioid for something, I guess for low back pain, and up to 13.7 in patients who had had 2 or more kidney stones. So kidney stones were clearly associated with chronic opioid use. And the questions that's not answered here is, did these patients have stones at that moment? I would think probably not. So their conclusions was that there was a robust association between a history of stones and current opioid use, even after adjusting for a variety of confounders. Limited by the cross-sectional design and the absence of detailed stone history, the study highlighted the impact prescribing urologists can have in the opioid epidemic. Now, the study that won the prize for best poster at this session at the AUA was presented by Andrew Portis, who's a urologist at the University of Minnesota. Here, they took 57 ED physicians in 3 emergency rooms and gave them education on the efficacy of using acetaminophen and ketorolac in the management of renal colic, and encouraged them to switch to stop using opioids. And the treatment patterns were observed, and they looked at what exactly happened. So here's what happened before and after this intervention, where they basically instructed ED physicians on the benefits of using ketorolac and acetaminophen as opposed to opioids. So they had a significant effect. Now, I think this is a modest effect. No opioid, 36% to 51%. And these were statistically significant. And opioid at discharge from the emergency room went down from 79% to 71%. So you might think that's not very impressive. It's statistically significant, and it was a successful intervention from some points of view. So my conclusions: opiate use in the ED management declined, this is Andrew's conclusions about his poster, declined after commencement of an opioid reduction program. Introduction of acetaminophen provided an additional non-narcotic analgesic option. They pointed out out that acetaminophen actually had more benefit than the urologist thought or that the ED physicians thought. Changing care protocols was achieved without compromising clinical outcomes. They had other data demonstrating that patients basically did well from the point of view of stone passage and the like. So here's the graph of that. Basically, you see any opiate, as they called it, not opioids, on the right, were decreased after their intervention, and they used more acetaminophen at higher doses in the middle there as well. So my conclusions were the gaps in the evidence do not really seem important from the point of view of managing acute renal colic. The studies are maybe not the best evidence. They're short. They don't look at long-term outcomes. They don't look at overprescription of opioids and the number of doses that patients had left after they had passed their stones, which I think are interesting. I think the AUA could be more explicit in recommending nonsteroidals and acetaminophen over opioids. They've acknowledged this, but it's not part of any current AUA guideline. But the gaps in implementation are clearly a different story. If there's a consensus about nonsteroidals being important, that hasn't translated into use in the emergency rooms. And so these AUA guidelines, if you think about it, they're not read by ER doctors necessarily. And that's a separate group of patients. Now, here's what I do, and this is what I tell patients how to pass a stone. This is a picture that was sent to me by one of my patients. She's followed my advice. She's gotten into the bathtub. She's got a half a gallon of Budweiser. She has turned down the lights and lit a candle. Let me just point out that I don't think that water intake is useful, because I showed you a completely obstructed kidney. You can't get water to that stone to force it out. All of the water is going to go out the other non-obstructed kidney. Alpha blockers I usually prescribe but as I said, they're controversial. I use over-the-counter naproxen. I give two doses twice a day, 2 pills twice a day, I should say, and that is the over-the-counter dose. That is basically like a prescription dose. It's relatively inexpensive. I stress relaxation. And if you say to your patients, how do you relax? Do you have, this is off the record, right? No, it's on the record. Do you have any benzodiazepines at home? Everyone says, oh, sure, I got a Xanax. Yeah, I have an Ativan. Everybody's got something. And I say, take an Ativan, drink some beer, turn down the lights. Robbie, we prefer wine. It's fine. And keep your head out of water. My nightmare is that one of my patients is going to drown passing a kidney stone. Get into a bathtub and take a sedative hypnotic. Not necessarily a great idea. But I'll point out that this is... when my patient sends me this picture, she says, David, I've passed that stone. Thank you so much. This was a brilliant prescription. So I think stones are common, aiding the ability to perform randomized trials for stone passage and analgesia. But my colleagues and I would like to know, what are the relative benefits of things that not easily studied? How would I do a randomized trial of alcohol, benzodiazepines, or guess what? All of my patients are smoking weed when they're passing stones. And so that medical marijuana thing is something that we've discussed. Is it possible to do a study of medical marijuana for relaxation? Because I think analgesia isn't the only issue. I think what happens with kidney stones is, and I've been there, is that you basically wind up in this kind of agitated state, and the pain is associated with the anxiety and the misery of all of that. And relaxation, I think, is a very important part of it. But you can imagine that doing medical marijuana studies in the United States right now is somewhat controversial, not easily done, but it's something that many of my patients report having some efficacy. So these are the important questions. Regarding all of the questions that Dr. Smith dealt with, if you took all of Dr. Smith's slides at the end about sickle cell and the questions about the framework and the issues, the gaps in the long-term evidence and the like, you could change those sickle cell slides to kidney stones, and I think I'd be pretty happy with that. Thank you to my federal funding of my studies of cystinuria, and the urologists in the corner here helped me with putting some of this together. Thanks for your time.